Hi, everyone, and thank you for joining the fourth session in our Age-Friendly Geriatrics Tele-ECHO series on chronic disease in older adults. Let's go ahead and get started. So today's lecture is going to start with a welcome and introductions and announcements, followed by our didactic on treatment considerations for diabetes management. Then we'll follow up with a case discussion and closing and reminders. Just make sure that you mute yourself when you're not speaking to prevent background noise. Everybody has been joined on mute, so if you do want to speak up, you can go ahead and unmute yourself at any time. Introduce yourself with your name and location prior to speaking. Always maintain confidentiality when speaking about your patients and refrain from using any identifying information. As you all know, we are CME accredited, and this session is accredited for 1 CME credit. If you do wish to receive credits, make sure that you fill out the CME form that is sent to you after this session. And certificates will be sent to you after the series ends. This is part of our HRSA Geriatric Workforce Enhancement Grant at UC Irvine, and basically this information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the US government. Let's go ahead and move on into our introductions. If you can, please go ahead and add your name, role, site, and location in the chat. We'd love to see where you're joining from. And we'll go ahead and have our hub team introduce themselves. I'm Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Project here at UC Irvine. Dr. Gibbs can't be here with us today, but let's have Dr. Sagel introduce yourself.
Welcome, everyone. I'm Sonia Sagel. I'm a clinical professor at the University of California, Irvine, Geriatrics Division. Welcome.
Thank you. Dr. Gurvich.
Hi, I'm Tanya Gurvich. I'm a clinical pharmacist, a professor at USC Pharmacy School, and my practice site is UCI Senior Health Center.
Thank you. And Dr. Campbell.
I'm Sarah Campbell, and I'm an assistant professor at the School of Nursing here at UCI.
Thank you. And Carlos.
Hi, everyone. My name is Carlos Garcia. I am the data analyst for a Geriatric Workforce Enhancement Program. Welcome.
Thank you so much. Happy to have everybody here today. And let's go ahead and move on into our didactic presentation presented by Dr. Tatiana Gurvich on treatment considerations for diabetes management.
Okay.
Go ahead and take it away, Dr. Gurvich.
Thank you. Next slide. So a similar talk using some of these slides was presented at one of our pharmacy conferences by the 2 residents I worked with last year. Next slide. So we're going to talk about medications used in diabetes management and focus on how to use them safely in an older adult. Next slide. So obviously diabetes is a very common problem in older patients. A third of our patients have diabetes, if not more, actually. Complications from diabetes increase cardiovascular death, increase the risk of dementias, and a lot of our patients actually, because they're demented, have hypoglycemic unawareness, and they may have slightly atypical presentation. And so it's really important to manage this disease state differently than you might in a younger adult. Next slide. So goals of care. So here's a table for A1C goals. Obviously, these are less stringent than they would be for a younger adult. So we're looking, in our clinic, most of our older adults are very old. So most of them are managed in the A1C range of 8 to 8.5, and sometimes even higher. And really what you're doing with diabetes is you're really trying to prevent functional impairment that results from it. So that's really the key in managing this disease. You don't necessarily have to chase blood sugars. Obviously, you want to avoid hypoglycemia, but we're a little bit less worried about higher blood sugars. we're always trying to reduce medication complexity, regimen complexity. And so the simpler regimen is always best because patients are much more likely to comply with it. And I think overall results are better. And we always want to reduce the risk of hypoglycemia. Next slide. So here's a fancy chart, kind of basically looking at how you would approach an older patient. And obviously, the healthier the older adult is, the fewer comorbidities they have, the fewer vascular complications they have, the more aggressive you're going to be at managing their diabetes. As they become more frail, more medically complicated, you become less stringent at managing their diabetes. You also have to take into account what the patient actually wants. If they're motivated to lower their blood sugar, if they're consistent in monitoring blood sugars at home, watching their diet, you could be a little bit more aggressive versus someone who just doesn't want to even test his blood sugar ever. You're going to be a lot less aggressive because you're trying to avoid hypoglycemia. Next slide. So what are some of the contributing factors to hypoglycemia in older adults? So I'm just going to focus on some of the medication-related factors. So obviously, polypharmacy and multiple comorbidities. Some medications are more likely than others to cause hypoglycemia. And so when we choose agents, we're very aware of which ones will make that problem worse. Obviously, insulin can cause hypoglycemia, and insulin secretagogues can also do it. So we're much more careful with dosing of those agents, starting with a tiny dose and titrating to a therapeutic level much more slowly. Again, you have to be aware of hypoglycemic unawareness, where patients don't realize they're hypoglycemic, and obviously that can be a very dangerous situation. So that's another reason to start to sort of reserve these medications in your really severe cases, and when you do use them very carefully. And obviously, kidney disease can exacerbate that risk. So you're always watching renal function in patients and fluctuations in that. Next slide. So now I'm going to go over basic medications we have at our disposal to manage diabetes. So we're going to go class by class. Next slide. Oh, before we do that, let's look at the ability of each drug class to lower A1C. I think this is a really interesting chart. I don't think people realize how effective some agents are and how ineffective others are. Biguanines, for example, like metformin, is one of the more powerful medications we have at lowering A1C, and that's why it's our first go-to. Sulfonylureas are also pretty effective. And so despite them causing a hypoglycemia risk, we still use them quite often at very low doses. Meglitinides, we're going to talk about them in a little while. They're sulfonylurea-like drugs, but with a very different pharmacokinetic profile. So they're also fairly effective. And the TZDs, these are things like Actos, are also pretty effective. Everything else is kind of lower down on the list, with a possible exception of GLP agonists. And if you look, the range is fairly wide, and depending on the article you read, they're either less effective or more effective. So that's kind of, I think it's a little bit of a gray area. Lifestyle modifications, so watching your diet, increasing your physical activity, is also very effective. And so that's something to keep in mind for your more functional older patients. And what I find interesting is just monitoring blood sugar increases diabetes or decreases A1C levels a little bit. So sometimes monitoring can really help and achieve your goals. Next slide. So let's start with biguanines. So this would be metformin. Metformin comes in two formulations: immediate release and extended release. Extended release metformin is really effective if somebody has diarrhea with regular metformin. A lot of times patients will complain of diarrhea, and it may be that they just don't tolerate the drug at all. And then you have to start extended release just as on a trial basis. But it could be because the initial dose of metformin was too high. So again, in geriatrics, you always start with the lowest dose available. So in somebody who's older, you would start with just 500 milligrams at bedtime, see how they do, and go up from there. So I would not start any older adult on 500 BID. I would just start with half that dose and titrate gradually. And again, the extended release drug is an option, and that can be dosed once a day. You want to avoid these drugs with seriously impaired kidneys. So with less than 30 mils per minute, you want to avoid them because they increase the risk of lactic acidosis. Long-term use can lead to vitamin B12 deficiency, so you want to make sure you're monitoring that carefully. Some advantages of metformin would be either no weight gain or minimal or some weight loss. So if you've got an obese patient who's trying to lose a little weight, that's a good one to start with as well. Lower incidence of hypoglycemia. Lower doesn't mean none. But it does mean it's less likely to cause it. And overall, it's pretty well tolerated. If you don't have GI side effects, you're really not going to have a lot of other side effects from it. So again, to eliminate nausea, vomiting, diarrhea, you want to really limit the dose and titrate up slowly. Switching to an extended release formulation can be helpful. Next slide. The next ones are sulfonylureas. So a lot of the sulfonylureas that we have are on the Beers criteria because some of the sulfonylureas like glyburide and glimepiride have longer half-lives, have active metabolites, and so they're more likely to have cause a hypoglycemic reaction. So we generally prefer glipizide over the other two. And again, all sulfonylureas can cause hypoglycemia. So the trick is really to figure out what the sugars the patient is having, and if they're having any low sugars, probably not your go-to drug. But if their sugars are generally high, over 200, you might start a low dose of glipizide. 2.5 milligrams is a very low dose, and if a patient agrees to do careful monitoring of their blood sugars at home, it can be very effective. There are differences between immediate and extended release formulations. The main one is dosing. So the maximum dose for glipizide immediate release is 40, extended release is 20, but it's generally used once or twice a day. When you have somebody on a sulfonylurea, if they're on insulin, you don't want to use both of them at the same time, because sulfonylurea is basically increased insulin secretion. If somebody's already on insulin, there's no point in having the combination. So when insulin is started, sulfonylurea can be discontinued. And if you're going the other direction, if you want to add sulfonylurea to someone on an insulin regimen, you want to get rid of the insulin. Otherwise, it doesn't make much sense. One of the long-term issues with sulfonylureas is they do cause weight gain. But a lot of our older adults don't get enough nutrition, so that may be appropriate in some patients. The most weight gain you get with glyburide, followed by glipizide and glimepiride. They're not preferred agents with renal insufficiency, but they can be used at low doses. So that's something to keep in mind. You can always use it, just lower the dose. Next slide. The next group of medications are not often used, and I wonder if we are underusing them. So these are also insulin secretagogues. They work very similarly to a sulfonylurea, but they don't have the structure of a sulfonylurea. But the main difference is kinetics. They work very quickly. They start within 15, the onset of effect is within 15 to 20 minutes of taking the medication, and the half-life is really short. It's just a couple of hours max. So really, it should be dosed around meal times. Sometimes you run into trouble with these medications, like in a nursing home, for example, when med passes are done before they get their food. And so you will give them either Prandon or Starlix, and then you bring them the food and they don't eat it. Then they'll get hypoglycemic. But it's really effective for someone who occasionally goes out to dinner, eats more when he does or she does that, and then you could administer these drugs right before they eat. So they can almost be used like a PRN, on a PRN kind of schedule, like you would use short-acting or rapid-acting insulin. So again, slow titration is really key. The risk for hypoglycemia really only exists when they don't take it with food. If they take it with food, that's kind of taken care of. If you skip a meal, skip a dose. And again, it may be appropriate for patients with irregular meal schedules. And just like a sulfonylurea would, because it increases insulin secretion, it will cause weight gain. Next slide. These drugs, I can never pronounce the name, so I always just say TZDs. They used to be used very frequently when they first came out. This was probably 15, 20 years ago. And then we decided that there's actually quite a few problems associated with these drugs. If you're as old as I am, you probably remember Resulin, which was released on the market and taken off because it caused severe liver toxicity. And then Actos and Avandia came out, and Avandia is now not a preferred agent. So we're kind of left with Actos. These drugs, they primarily work by increasing insulin sensitivity and utilization of glucose in peripheral tissues. And they're very effective at managing diabetes. They're also really inexpensive. So if cost is ever an issue in your low-income patients, a lot of times they will be started on these medications. You have to use them carefully. If your patients have a history of CHF, not a good option to try, because these medications are known to exacerbate or even cause heart failure. With something like Avandia, you don't want to use it at all because there were reports of increased risk of MIs associated with that use. So that's one of the reasons we're just using pioglitazone. There is an increased risk of bladder cancer with this class of drugs. So somebody with a history of that is not a good candidate. Long-term, there is an issue with an increased risk in fractures. So if they have very severe osteoporosis already, probably not a great option either. And one of its main side effects is edema, sometimes related to CHF, sometimes not, and weight gain. And because of Resulin and because of all that liver toxicity history, it's still recommended to check liver function before you start these drugs and monitor throughout treatment to make sure liver function is not altered by these medications. With Actos, it's a very rare event. You still check LFTs, but I've never seen a problem with it. Next slide. This is the newest drug class that we have in managing diabetes. These drugs inhibit sodium glucose cotransporter in the proximal renal tubules, reducing plasma glucose concentration. So they work by helping excrete glucose. There are now 4 medications in this class, Invokana being the first one on the market, and then all the others kind of followed. There's a lot of buzz about these medications because, studies have shown that they prevent hospitalizations for heart failure, for chronic kidney disease. They may actually be renal protective in patients who still have renal function that's intact. There's a cardiovascular benefit associated with some of them. And this always gets confusing to me, because when a new drug hits the market and there are more than one drugs in the same class, different studies are done with different drugs. So for example, even in this slide, canagliflozin, empagliflozin, and dapagliflozin have been shown to prevent hospitalization for heart failure and CKD, but only canagliflozin and empagliflozin have been shown to prevent MI, strokes, and cardiovascular death. That's because the studies were arranged that way. It may be a class effect. We just don't have the data on all of the medications within this class. Because what they do is, because they work by excreting glucose, as you can imagine, some of the side effects of these medications would be frequent UTIs, genital fungal infections, increased frequency in urination, some weight loss, which may or may not be a good thing, and hyperkalemia, primarily seen with the first drug on the market in Vocana, but because of its mechanism of action, it's potentially a class effect. Again, they have been shown to be renal protective in patients with creatinine clearances above 30, but have not been studied in patients with severe renal impairment. Next slide. Okay, DPP-4 inhibitors. So these drugs, so this particular class is an enzyme inhibitor that prevents the breakdown of incretin hormones and increases insulin release in conjunction with a meal. So we've got 4 medications in this class. The one we very commonly use is either Januvia or Tradjenta. Tradjenta's main advantage is that it does not have to be renally adjusted. You could have really poor renal function and the dose is still 5 milligrams daily. With Januvia, we're always having to monitor renal function and adjust accordingly. Because these drugs work around mealtime, so insulin release is in response to a meal, they're much more less likely to cause hypoglycemia. And so that's one of the reasons why they're commonly used in older adults. If you remember the A1C lowering table, they're a little bit less effective than all the others, so they won't be as effective as something like a metformin or an Actos or a glipizide, but they can help in management of diabetes. With a couple of these medications, they've been associated with heart failure and pancreatitis. That's saxagliptin and alogliptin, and that's probably the reason why we don't use them much. It hasn't been shown to be a problem with Tradjenta or Januvia, and so we still use them. The biggest side effects these drugs have is arthralgias and a little bit of peripheral edema. So that's something to keep an eye on when you're starting these medications on patients and titrating up on the dose. Next slide. GLP agonists kind of work on the same enzyme system as DPP-4 inhibitors. They're just the agonists of the receptor that stimulates secretion of insulin in response to a meal. We've got 5 drugs in this class, and most of them are IV, or not IV, but injectable, sub-Q. So that's really, in an older patient, that might be a showstopper for them because they don't want to stick themselves even once a week. You know, when Byetta first came out, you had to do it twice a day, and that was a complete no-go. Now, most of these drugs can be, even Byetta came up with a weekly injection that you can do. But for some patients, even that's too much. They just don't want to stick themselves. There is an oral form of this drug. It's called Rybelsus, but it's really poorly covered. You basically have to trial a sub-Q medication before insurances will even consider covering them. The reason these drugs are very attractive is because there's a low risk of hypoglycemia. The main adverse event is nausea, vomiting, diarrhea. And again, if you titrate slowly, you'll eliminate that side effect, generally speaking. And they can cause weight loss, which is another attractive part of it. You don't have to renally adjust if you're using liraglutide, dulaglutide, and semaglutide. Some of them have ASCVD benefit, again, because the studies were done in those drugs. And the reason they cause weight loss is because they slow gastric emptying. And so the main precaution for them is to avoid them in the history of pancreatitis and thyroid cancer. That's a contraindication. But in the scheme of which drug do you use when, these are pretty high up because low risk of hypoglycemia, potentially weight loss in your predominant population that's obese, and that's one of the reasons they're diabetic. and relatively well tolerated if you titrate the dose gradually, and relatively convenient because most of these are just once weekly injection. And I'm kind of excited to see when this PO formulation starts getting covered, because once that starts getting covered, I think it's really going to revamp how we treat diabetes in our older adults. Next slide. Then I want to spend a little time going over insulin. So a lot of time, you know, there's so many insulins out there. It can be really confusing about which one to use. So for your basal insulins, there are now 5 basal insulins, if you consider NPH basal. It doesn't quite fit in this category. It's more of an intermediate insulin, but just historically, like when Lantus came out years and years ago, in clinical trials, it was compared to NPH. So with NPH, there's a clear peak, and with Lantus, there isn't one. And that's how it became very popular right away. So if you look at the kinetics of these insulins, they're all a little bit different. And that's something to keep in mind, because obviously these drugs are going to cause hypoglycemia in older patients. And so you want to be really careful not to overdose our patients on insulin. So just looking at the truly long-acting ones, so that would be Levemir, Lantus, Basaglar, Toujeo, and Tresiba. The only ones with a pretty consistent 24-hour duration of action is Lantus and Basaglar. All the others are either way over, like Tresiba, 42 hours, so much more likely to cause hypoglycemia. Toujeo, 36 hours, still pretty likely. Or Levemir, where you can't quite tell what its duration of action is going to be. Some patients it's short, some patients it's close to 24 hours. So I think they're more difficult to use. Like sometimes we use Levemir BID, sometimes we use it once a day, and it really just depends on how the patient breaks the stuff down. With Lantus or Basaglar, it's pretty predictably 24 hours. You would still use it BID if your doses are higher, just to break the dose up a little bit. But when you're starting out slowly at a low dose, you can always dose Lantus or Basaglar daily. So the benefit of these is that because they're long acting, onset of effect is long, duration of action is long, you're less likely to get spikes in blood sugar, and so you're less likely to get spikes in the other direction. So you're less likely to get hypoglycemic than you are with a rapid acting or a short acting insulin. They do increase, insulin increases weight, so that's an issue. And again, you don't want to use insulin with all the other secretagogues. So you want to stay away from sulfonylureas and meglitinides when you're initiating insulin, because that really increases the risk of hypoglycemia. And pens versus vials, I'm going to show you, that comes up in the next couple of slides. Next slide. So prandial insulin, this is a mealtime insulin. You've got your options of all the short-acting ones and your regular insulin. So traditionally, rapid acting insulin is considered to be a better alternative to the regular, but not necessarily in an older adult, because you have to be pretty organized with your rapid acting insulin for you to, get up, inject it, and then eat within 15 minutes of injection. Otherwise, you're going to get hypoglycemic. In your older adult who may have a slower start to the day, regular insulin may actually be safer, because you've got a little bit more time before it kicks in, and you need to eat. So that's something to keep in mind. Obviously, rapid acting insulin is going to have a shorter onset of effect, a shorter peak. So the problem with regulars, for example, if you give it at breakfast, it may still be lingering at lunchtime. So if you don't eat lunch at a specified time, you may get hypoglycemic from that lingering regular insulin that's still there. So obviously, you don't use it if you skip a meal. You avoid it at bedtime because it's much more likely to cause a hypoglycemic response. You definitely don't use these with sulfonylureas or meglitinides, again, because they're secretagogues. You want to avoid sliding scale whenever you can in an older adult, simply because it's complicated. You know, you have to check a blood sugar, you have to draw up a dose. It just really complicates regimens and really potentially exposes the patient to hypoglycemic reactions. So on the Beers criteria, they talk about not using sliding scale by itself. If you use it in conjunction with long-acting insulin, it's okay in some cases, but in our clinic, we really try to avoid complicated regimens like that. Next slide. And then you've got combinations. A lot of these are 70-30, 75-25 combinations where you've got primarily NPH or long-acting insulin like Lantus with a rapid acting or a regular insulin. So generally in your average diabetic, these are not recommended anymore because it doesn't provide very tight control. But in an older adult, they may actually be a simpler regimen to use because you're only injecting twice. So you're injecting in the morning. The breakfast is taken care of by the rapid acting insulin. Lunch is taken care of by the longer acting insulin. And in the evening, when you injected, the rapid acting takes care of dinner and the long acting takes care of the rest of the nighttime. So it's if you're using insulin in an older adult, this is a way to minimize injections. And so if you're thinking, you know, Lantus with rapid acting insulin together, this might be a simpler solution for your older patients. And again, these are available in vials and pens, but I'll talk about all that in the next when we start talking about formulation. Next slide. Okay, so diabetes considerations in an older adult. Next slide. So in an older adult, obviously you're worried about polypharmacy. You want to limit pill burden for a patient. You want to give them probably the most effective things at the lowest effective dose and try to limit the number of medications you're using. You want to minimize fall risk. So again, that's another reason why hypoglycemia is such a dangerous effect because it obviously can contribute to falling. You're dealing with your cognitively impaired patients who may not understand how to use some of these injectable products and how to check blood sugar and how to figure out the right dose. So that really complicates the picture. And you're concerned about urinary incontinence. I mean, obviously, uncontrolled diabetes can cause frequency in urination and potentially incontinence. But some of the medications can, like the SGLT2 inhibitors, can also increase that risk. So that's why they may not be appropriate in all of our patients. And really, when you're dealing with an older adult's diabetes, you should really be considering de-escalation of therapy based on the goals of care for each individual patient and complications of the diabetes in the presence of these geriatric syndromes. Next slide. Okay, so which medications are particularly inappropriate? So the SGLT2, so these are things like Jardiance, for example. You don't want to use them in your patients with UTIs with a history of fungal infections. And we have had patients in our practice who've started these drugs and immediately developed yeast infections. So we have to discontinue them. If they already have urinary frequency, chances are it'll get worse. And these drugs also lower blood pressure. And so if there's a history of hypotension, probably not the best choice for your patient. Sulfonylureas and meglitinides should be avoided with a significant history of hypoglycemia. TZDs, heart failure, fall risk, osteoporosis risk, those are the kinds of patients you're going to stay away from with these medications. GLP agonists, the biggest problem with this is GI. So if they're low weight, if they're having trouble keeping food down, this may make them more nauseated. So you want to probably not the first choice. And the other issue is the fact that it's injectable. And if they're losing significant weight, you don't want to use them. Rapid acting insulin, obviously risk of hypoglycemia, and again, inconvenience because you're dealing with multiple administrations. you know, if you're using a combination, you don't want to use different vials where you're having to mix this stuff. You want to get a formulation that's already a 70-30 or a 75-25 formulation, because you don't want to have the additional risk of screwing up the vials and what did I draw up first and what did I draw up second. So you want to make it as simple as possible. Next slide. So here's some dosing guidelines. So dose based on weekly fasting blood sugar values. If 50% of your values are above goal, you might increase your dose by 2 units, so a very small amount. You're going to make very gradual increases. And if your fasting values are less than 80, you're also going to decrease the dose by a very small amount of about 2 units. If for your prandial insulin, if you're using less than 10 units total daily dose, you probably can discontinue the insulin altogether. Again, when you're titrating prandial insulin up or down, you're going to do it much slower than you would in an average adult. When I worked in a free clinic where we saw everybody in diabetic and who was diabetic, and these patients were in their 50s, we would change doses by 5 to 10 units at a time. And I was freaking out because I hadn't done that in about 15 years. So it was quite an adjustment. And again, your fasting goal is going to be less aggressive. So 90 to 150 is a completely reasonable fasting range for an older patient. Next slide. So this is where dexterity, cognitive function really comes into play. You know, I don't know if you remember, but these insulin syringes are really tiny. And these little gradations that show units are really tiny. I'm not geriatric. When I look at this insulin syringe, I can't, this is magnified 100 times. I can't see the little check marks, you know, 2 units, 4 units. It's really hard to see. And I'm not geriatric yet. So imagine your 85-year-old trying to draw up this insulin and trying to get an accurate dose. This usually doesn't work. Again, the syringes are tiny, the plunger is tiny. You have to have really good manual dexterity to be able to accurately draw up the amount you need and inject it. Next slide. The pen is much easier. So you attach your needle over here. It's a pretty wide-based needle that you just screw on. There's a little mechanical thing there's a clicker. This is the clicker you move, and this will adjust the number of units. And the size of the units is much bigger, so you can easily see them. The syringes are pre-filled, so you don't have to worry about drawing anything up. So this is really ideal for an older adult. If they have to do insulin, this is the way to do it. Next slide. When I help our providers manage their diabetic patients, I really feel like a nutritionist, and I'm not really trained as one. But you basically want to know your patient's 24-hour recall of what they ate. And when you ask them meal by meal exactly what they had for breakfast, lunch, and dinner, you realize how carb heavy most of their diets are. You know, they'll either love fruit and they don't like green apples and berries, which are less sugar. They love pineapple, they love mango, they love watermelon, which is all sugar and water. So getting them to switch patterns is often difficult, but it can be really effective. You know, I'll show you the slide at the end of the presentation where it says if your A1C is greater than 10, you have to start insulin. But I've had patients who were with an A1C of 12, and we seriously sat down and figured out what they could have for each meal, and they were able to bring their A1Cs down to 8. So without insulin, with just oral meds and a little dietary changes. Now, the older your patient is, the more demented they are, the less likely these dietary changes will happen. But it's still, I think, worth a try to just kind of go through every meal and figure out if there's anything we could substitute for the bread, the tortillas, the high sugar fruit, the ice cream that they have on a daily basis. Physical activity is also really important. I tell my patients who are able to walk and exercise, you know, there are two ways of lowering blood sugar. You can increase your insulin or you can go for a walk. So if they're amenable to walking, I would really encourage them to whatever the starting point is, increase it by 5 to 10 minutes a day and kind of work gradually, as obviously it's safe for them and as they can manage it. And you know, improving diet and increasing exercise will almost always reduce weight and potentially improve diabetes management, and actually help with other things like osteoarthritis and generalized pain that you sometimes get because you're just too heavy and very sedentary. Improve your cholesterol, blood pressure, everything gets improved with managing nutrition and physical activity, obviously. Next slide. So this is the big algorithm of what you're supposed to use when. So first line drug therapy is always metformin and always lifestyle modifications. And again, this is where that arrow goes to if your A1C is greater than 10, insulin therapy, not necessarily in your older adults. I would really consider, if they're amenable to changing diets and if they're really resistant to injections, this is when you come in, okay, well, your A1C is 10. We probably don't want it to be at 10. Let's maybe change diet a little bit, or let's get you to walk a little bit during the day, and maybe that'll bring it down in addition to the oral agents. So here, they kind of break it down to whether or not you have high ASCVD risk of heart or not. So if you don't have a ASCVD risk, you're probably going to end up using some of these oral agents, like all the ones we talked about, like Tradjenta or Januvia, like some of those injectable GLP agonists that we talked about, things like Jardiance, or things like Actos. And then these just kind of, you're going to pick and choose what you're going to use. The cheapest things and probably the biggest bang for your buck is going to be Actos and glipizide. Very inexpensive, covered by every insurance. And if you pick the right patients to use them in, you can treat your diabetes very, very easily. A lot of this pathway involves using GLP agonists. Again, in our patient population, it's always tricky because it is an injection, and most patients just won't go for it. And I think that's it. Oh, so key recommendations: emphasizing lifestyle modification, diet and exercise, metformin first line, start low and titrate slowly, monitor for hypoglycemia, screen for geriatric syndromes, and individualize goals and treatment plans. I think that's really the biggest issue with older adults. You have to look at your older adults, look at what his or her lifespan is going to be, look at how much they're interested in lowering their blood sugar, how much monitoring they're willing to do, and really individualize your regimens based on that. I think that's it.
Thank you so much, Dr. Grivich. Does anybody have any questions for Dr. Grivich before we move on into the case? Okay, if anybody does have any questions, feel free to type in the chat and we'll try to get to it before the end of the session. Let's see, and you will get these slides right after this session. So we'll have Dr.